You know what? I'm not trying to like pat my own back or anything, I promise, but if you feel comfortable in a place, you're more likely to yawn because it's part of your like wind down. So if you don't feel as intimidated by this class or as pressured by being here, maybe that's part of it too. Like, I don't know, but it's different than being at work, or it's different than being in classes where it's very pretentious or something like that. Yeah. So if I could just offer it as just a discussion about these things, I would love to do that for you guys. But, yeah. Very stressful from what I hear.
Yes, it is. I don't like being treated like a child.
Right. It's crazy because I mean, like, I am a person that calls on people by name and I expect you to participate by name, but yet it's still less stressful than some of the other classes that you guys were taking. I'm aware of it. I'm just remarking on it, you know. I like it, so yeah.
Other class on Tuesday.
Yeah. That lab, that's my busiest. That's my fullest class. And it makes a difference. It does, like, I think in a negative way. I mean, I like working with the smaller group, more personal interaction, and you know more like what's going on. I don't know. I don't know how, but somehow it does work out that way. Imagine being in one of those classes like they have in like Stillwater. It's like 300 people classes, you know, like how can you get personal interrelationships with that? You can't. So we'll wait a little bit longer to make sure that everybody's here. We've got 4 in here and then we've got 5 online. That's 9. If you are online, please go ahead and log in, sign in to the thing. We're gonna get started in a little bit. I'm probably gonna give maybe 5 minutes for everybody else to join. Maybe. Okay, yeah, you're fine. Yeah, whenever you get here, you know the drill. I'm not too picky about it as long as you show up at some point. Okay. 9394834. Or I could just look at the number at the bottom of the screen. It just says 8. I could just see that. That's uploading. And then to download this. All right. We still got 8. We'll go on here in just a minute. Oh, since nobody is using this classroom after we're done with lecture, I'm just gonna have the lab review in here because the lab is cold, the stools are uncomfortable. We'll just stay in here. I did put a note on the door too, just in case for some reason other people showed up during the lab review, but yeah. We'll be in here. Chapter 13 was infection disease. Yeah, you're welcome to stand up and take a mini break before we go into that, yes. Probably need it. Okay, good. Got that out of the way. Mhm. Right. I gotta climb up on my chair. We're gonna get started with the review, or not the review. We're gonna start with chapters 13 and 14 first. This shouldn't be as taxing as like 6 and 10 were. Those were pretty heavy stuff. This is not as heavy as that, but there still is plenty of discussion to be had. Make sure that goes away. So we'll get going with this. Again, if you're online, if you're joining us online via Zoom, then you can still join in on the Kahoot. I entered the code in there also to join the Kahoot. So make sure you're signed in the Kahoot. If you are on Zoom and I call on you for a question, because I'm gonna call on everybody just the same as usual. If I do call on you, I'll move this a little bit more central. If I do call on you, then you can either type your answer in the chat or you can speak it over your microphone. I don't care, but you do still have to answer the question. FYI. Okay, so let's get started. So chapter 13 dealt with infection and disease. So we'll get into some of those concepts here. First question, what is disease? Don't overthink it. There is a more specific answer for this, of course, but yes, join code is here. The awkward keyboard situation. I think that's it, right? 93948. Yes, I think that's it. I'm trying. All right. So disease. This is, I say anytime you feel unwell is our answer here. Now, that's not entirely true. The better answer for this would be deviation from what you perceive as health. So when you're feeling unwell does apply here, but not every time you're slightly feeling unwell, right? Yeah, okay, so this is an area where I wouldn't put this as a test question specifically because of that. But to clarify, who's my first person here? Jessica. Jessica, you're online with us today. Jessica, can you name a disease that is not caused by a microbe? So that'll put it into perspective why we can't just say disease is only caused by microbes. Now in this class, we're talking about diseases that are caused by microbes, obviously. But there are plenty of diseases out there that aren't caused by microbes. We'll see if Jessica can name one of them. A little bit of just waiting and letting people click on this. So dermatitis, yeah, I mean, I'm fine with that. I'm fine with dermatitis. It's not caused by a microbe. It's caused by your own body, right? So we've got dermatitis. We've got some other ones that are maybe even going to sound, you're going to feel like ridiculous for not thinking of them, but at the same time, they do apply as diseases. For example, we've got diabetes, heart disease of various sorts, especially cardiovascular, like artery, like atherosclerosis, artery diseases and stuff like that. Stroke and cancer. A lot of these are going to be basically, we could talk about Down syndrome. We can talk about all sorts of things that are not, propagated by microbes, but are still considered disease. So they're deviation from what we would consider to be a healthy situation, a perceived health. All right, so that would those would be examples of diseases that are not caused by microbes. I mean, just FYI. In fact, most disease in humans are not caused by infectious sources, right? Actually, whenever we count up how many other deviations there could be. So easy enough, starting off with that. Okay, next question. When resident microbes inhibit infection, what is that called? Our next person is going to be Jonathan. Jonathan, I know you're joining us online as well. And I'll get you a question about this in a second. All right, so this is called microbial antagonism, which is one of the major concepts in chapter 13. The idea that our normal microbiome prevents the growth of bad guys there. So Jonathan, my question for you is, can you give me an example of one system in the body where this is obvious that this would be happening? So if you can name one system in the body where we have microbes basically protecting us, their being protects us from infection. Yes, so this is I feel like the obvious one, the intestinal tract. We've got so many microbes in our intestinal tract. In fact, I brought it up before, but this is a good time to mention it. And I'll bring it up again whenever we get into Unit 4 and talk about GI diseases. But in just 1 centimeter of your colon, there are so many microbes in that 1 centimeter of your colon. We know your intestines are like feet long, right? Multiple like feet long. So in 1 centimeter of your colon, there's so many microbes in that 1 centimeter that there's more microbes there than there have ever been people on the planet in the history of the planet, ever, all of them combined. Just in 1 centimeter of your colon. Wild to think about. There's so many microbes there. And each one, and you guys have heard me say it before, and I'll say it again, but I think it's a great example. Think of your body as a big stadium, and there's seats all over throughout your body, in any body system, in any tissue. There's a seat where a microbe could sit down and live and take up home there. And the idea is that with microbial antagonism, if good guys sit in the seat, then the bad guys can't. Or at least the good guys can make things to deter the bad guys, or make use up the nutrients that the bad guys would need, and all sorts of stuff like that. There are some parts of our body. Like your central nervous system and your bloodstream in general. So your cardiovascular system and your central nervous system that are sterile, they're free of microbes, but they're still open stadium seats. But that's why we have to have those be closed systems and maintain them as closed systems. We can't let microbes get in there because it is literally just an open stadium. It'll be really easy for microbes to take over and overgrow that stuff. That's why it's such a big deal if we do find microbes in the CNS or in the cardiovascular system. It's so severe for that reason. Okay, good job. Next question. Question 3. When do we first begin being colonized by our own microbiome? And Cassie, you'll be our next person. Okay, so as early as in the womb, potentially, but we know that we're getting exposed to microbes in the vaginal canal during birth. And if you're born by a C-section, then you'll get exposed to microbes with whoever's contacting you after you're born by a C-section. But you can already imagine by me just bringing it up that quite obviously, if you're born via a vaginal canal versus being born via a C-section, you're exposed to quite different microbes in different populations in those two situations. So that can lead to different kinds of colonization effect from there. My question for Cassie is, aside from nutrition, what benefits are there potentially from breastfeeding? Immunity. Okay, so that's the best one that I can think of too. So there's two really big, other than nutrition. Okay, that's the number one thing for breastfeeding, right? It gives the baby nutrition. Easy enough. But breastfeeding has two other pluses from it. The first one is immunity. So in breast milk, as well as in the colostrum that comes with your first feedings, we're providing antibodies to the baby that gives it protection, because babies don't get their own immune system until at least 6 months of age. It's not really fully formed until about a year to 18 months. And that's why we wait with our immunization cycles until they're at least 18 months old. But babies don't have their own immune system until at least 6 months old. So they can't even be immune to anything until that old. So we get that from breastfeeding. So good answer there. Another thing that we get from breastfeeding is the microbiome. And so we get more microbes from breast milk. So we actually know that milk isn't sterile. We all know this. It's actually why we tell you shouldn't drink unpasteurized cow milk. Part of that is there's poopy all over their udders and stuff like that, and we don't need that in the milk. There's also microbes just naturally in the milk, and it's the same for human breast milk too. There are microbes in human breast milk, and they're actually there because they can help digest the breast milk and the sugars that are in the milk, but the baby doesn't have a microbiome in their gut to help them break down those sugars otherwise. And so this is actually a huge thing, because if the baby can't break down the milk, then they can't get the nutrients that they need, but it also can cause distress in the GI tract, which is why if you're feeding formula, you're more likely to have a colicky baby and have a baby that has GI issues than if you have a baby that's being breastfed. And one thing that one of my other students in my other class brought up is, just because you can't solely breastfeed, doesn't mean you can't supplement with your breast milk and supplement with the formula. So if you can feed your baby even a little bit, your baby's still going to get some of that benefit from the breast milk. Highly, highly encourage it. Of course, there are situations where you can't breastfeed. Number one, if you're like a surrogate, got a surrogate and you didn't give birth, or you adopted the baby or whatever, you're not going to be breastfeeding the baby. So if that's a situation where you couldn't be breastfeeding that baby, then I highly recommend using formula that has probiotics in it. So they have the microbes in it that can help with digestion and stuff like that. I didn't want to leave that out and not touch on the importance of breastfeeding in the microbiome, as well as the immunity that you get from the breastfeeding as well. So it's good. All right, getting to the infection stuff. What is it called when an infection comes from within your own body, and not introduced from outside? It came from your own body. Haley, you'll be our next one. Try to give you guys a little bit of heads up here. Okay, so if it comes from inside of your own body, it's an endogenous infection. So Kaylee, I'm going to ask you to give me an example of an endogenous infection. You don't like when you get to it. I'm going to let you cook a little bit, and we're going to talk about exogenous ones in the meantime. So Kaylee's going to give us an example of an endogenous infection, an infection coming from within your own body. Exogenous infections are the infections that come from outside of the body. And that literally is most of the ones that we think of on first, thought. Things like the flu or COVID or whatever. Those are being introduced from outside of your body and then inside. Yes, I think that's the best example that we have. A UTI is an excellent one. So yes, absolutely. Not what I meant to click on. I want everything. So yes, so her answer was a UTI. So almost always UTIs come from, for women, I mean, especially, okay, it usually comes from your own colon, your own anus. And so those bacteria migrate into your urinary tract. And it's usually E. coli that is the propagator of that. I would say it's 80 to 90% of UTIs. I don't say that, the facts say that. 80 to 90% of UTIs are caused by E. coli from your own body. And so that's not only a hygiene thing. Can it be a hygiene issue? Yes, but we got a lot going down there. If we're having sexual contact with somebody, there's a lot of mishing and mashing around that can lead to a spread of that bacteria that is right nearby, and stuff like that. So that puts that a little bit into perspective, how that can happen. Now, this is a situation where that E. coli belongs in your GI tract, sitting as one of your microbial antagonists, part of your microbiome, in the stadium seats in your colon. It doesn't belong in your urinary tract. So this is also a situation of an opportunistic pathogen. So this chapter also talks about opportunistic versus true pathogens. So we'll get into that in a little bit also. I don't want to give too much of that away. But the E. coli would be an example of an opportunistic pathogen. It's taking that opportunity of being put in a new environment where it doesn't belong and then growing and filling up the stadium seats in that new environment. If I took E. coli and you had a cut and somebody rubbed E. coli in your cut, it could potentially enter your bloodstream and grow there as well. Still would be considered an opportunistic pathogen, still would be considered, in that case, endogenous, but it's a little bit weird. We're getting weird with it then. But yeah, if it came from your own body, that's endogenous. Many people harbor staph as a normal microbe on their skin. If you get a deeper cut in your skin and the staph goes into deeper tissues like your dermis instead of just your epidermis, then you could get an infection from staph like that too. It's still endogenous and will be coming from your own body that way. And still technically an opportunistic infection. Many of our endogenous infections are opportunistic. All right. What is a virulence factor? Who's my next person? Jillian. I'm going to ask Jillian, what is an example of a virulence factor? Even generally. We've talked about quite a few of them throughout the course. So a virulence factor is anything that helps a microbe establish pathogenicity. This is a little bit fancier way of saying it helps it cause an infection. Okay, so anything that helps the microbe cause an infection, we would consider it to be a virulence factor. Right, and exactly. So capsules would be one that's a common one that we've talked about a lot. That sticky, sugary coating that helps evade phagocytes, obviously would be a virulence factor. Another one would be flagella. Flagella help with motility. That's something that helps them establish infection. Fimbriae, which are attachment proteins, those can help establish infection. In fact, that E. coli that causes the UTI, that is a specific kind of E. coli that has more fimbriae. It's able to attach, so it doesn't get rinsed out by the urine in the urinary tract. And stuff like that would be considered a virulence factor. Anything that helps them start the infection. Good answer. All right, next question. My next person is going to be Cielo, if you're here. Which of the following are signs? So I'm going to ask Cielo to tell me the difference between signs and symptoms. If you're here. I don't see her. Okay, so we'll move on. Dylan, if you can tell me the difference between signs and symptoms whenever we're done with this. I'll let you cook with it a little bit. Okay, so our signs here. First, before I get into too much detail with this, do you know the difference between a sign and a symptom? It's okay. I know what you're getting at, yes. Okay, yes, so that's good. So I get what you're getting at here. So we'll clarify this. And so what he's saying for those of you online who probably can't hear. A sign is something basically that you can measure. It's tangible, it's measurable, it's verifiable. And one of my students in one of my other sections came up with a good way of kind of basically calling out the difference between these. Yes. So, yeah. So a sign is like, if you think of sign language, you have to see it in order to understand it, right? So that's how one of my other students remembered it. Whatever works for you. I think of stop signs, and those are physical, tangible things that you could actually interact with. Symptom is a little bit more vague, and it turns out it is that way. So symptoms are going to be reported. So we can palpate and verify that the lymph nodes are swollen. We can actually see that white blood cell count in our values that we get back from the lab. We can actually measure their fever with the thermometer. Nausea, that's a reported thing from the patient. We can actually measure that or really verify it. Exhaustion, same thing. We might be able to see that they are exhausted, but can you actually measure that or validate it in any way? And pain. Pain is a tricky one. So pain is one of those ones where in my last class, I had a lot of students arguing with me, well, no, we have that scale that we use with the pain scale. Well, it's very, very subjective as far as that pain level that they're experiencing, let alone anybody can come in and you will see it. I see Asley here and you guys have probably seen it too. In a hospital, every single day, you're going to have people coming in seeking pain medication. And they're going to say they had a level 10 pain every time. and that they need the Dilaudid or they need the fentanyl or they need whatever it is. And how do you actually validate that? Now, you guys also probably know that in those settings, if a patient comes in saying that they have pain, you have to treat their pain. You can't you'd say like, well, you've been in here every week. We're not going to treat it. You're drug seeking. But you can treat their pain, give them their medication, and then try to help them find, rehabs and things like that as well. If there's indication that they might be drug seeking. That's the hard thing with pain is that it's very subjective and you don't know what somebody's level 10 is compared to another person's. And what you will find almost exclusively, guys, I have a lot of tattoos, right? Go to any tattoo artist ever, and they will tell you women sit better than men for a tattoo because women have a higher pain threshold, period. By far, like nobody's going to question it. And we can say it as medical professionals and see it like we know that women have a higher pain threshold. They're built to, they have to give birth and things like that. They have periods every month. That can be extremely painful. There's usually no doubt about it. But then when a woman goes to a doctor and they've been saying, I've been having pain XYZ and I'm just having a hard time functioning, the doctor will usually say, well, take some Tylenol and go home. Like, what's your problem? And how many times, ladies, have we heard about, women having debilitating period pain and we're just expected to function just like any other person would when they're not having pain, just because it's something that we're supposed to experience every month. So there's just stuff like that. And that perception changes as well. For somebody that's having chronic pain, so I have students that deal with patients who have sickle cell disease. These are people that have extreme chronic pain regularly. Their level 10 is going to be a level 10 that you would never be able to tolerate because they're used to having pain. And what they might call level 5, I might experience as like blackout level pain because they're just so used. So that pain, we just have no way of measuring the pain and having perception about what that patient is actually experiencing. That is actually why we have it written in law, basically, that you have to treat somebody's pain if they claim to have it, because there's no way to say that they aren't. It really just isn't, or that they weren't having pain. There are, of course, indicators of something like a level 10 pain. Fortunately, there's usually some physiological factors involved. If somebody's having level 9 or 10 pain, you're usually going to be seeing sweating or things like that you can't really fake as easily. Usually something is going to have been there, or they'll be passing out from the pain. But if they did pass out from the pain, or they did have level 10 pain, and now they're here and they're not having the pain anymore, how do we validate her or not? So that becomes a big question. But if you can actually verify it yourself, that'll be a sign. So good. All right, next one's going to ask us about symptoms, the other side of the coin. All right, which of the following were symptoms? We have a little bit different choice here. All righty. So this one is going to be pain, nausea, and fatigue, things we can't measure. So my question, it's going to be in our activity too, but we're going to knock it out anyway. My question is for Tanya. Surprise, I meant to give you a heads up and I didn't. But Tanya, can you tell me why nausea is a symptom, but vomiting is a sign? So just getting back to that same ideology. Why nausea is a symptom, but vomiting is a sign.
Because the patient is feeling the nausea, you can't see that,
Right.
but the vomiting is something that is visual and you can see.
Right. Exactly. So if that helps you guys, so the sign there, the vomiting, you can actually see that the patient is vomiting. Now, that patient may have vomited up everything they have to vomit, but they're still heaving and they're still having attempt, like it's still happening to them out of their control. And that still classifies as vomiting, emesis, as you want to call it in the medical field, right? That nausea there, though, it's very difficult to quantify that they're actually having or experiencing that nausea. So excellent answer there. Same idea with the signs and the symptoms. Beautiful. All right, what is the term for lasting effects of an illness, even well after it has been cleared? My next person is Duncan. And I'm going to ask you to give me an example of this. All right, good job. So this will be called sequel. I say good job. It wasn't the majority answer. So I get a lot of people mixing up syndrome and sequelae. And we'll go over what a syndrome is in a moment. But sequelae is the term for whenever you have an illness, you've cleared it, but you've got lasting effects of it. So Duncan's going to give us an example of that. Hopefully. No pressure. You're all right.
I was gonna,
So think about you don't have like, if you get a viral infection and you don't have the virus anymore, but you've got health problems left over after the fact that you cleared the virus. So
I mean, could it be like? Okay.
you're all right. I know that you know these too. I know if I were to give you an example and ask you, is it an
Could it
example of
be
it?
like, I don't know, for example, like COVID in a way where you're so like.
That
experienced,
does
like,
count.
the
Mm-hmm.
fatigue and all that stuff.
Yes. So his example, for those of you that might be listening online, his example basically is like long COVID. Like after you have cleared the COVID virus, people still have, fatigue, maybe trouble breathing, and then not being able to taste and smell things for a long period of time. These are sequelae of having COVID. So you're absolutely right. I'm going to give you a more obvious one, or maybe one of you guys know the more obvious one that I'm thinking of. Anybody want to guess what it is? Polio. When you have polio, you guys know this, right? So we don't see polio a lot anymore, but we know about it enough that you can have polio, you can clear the virus, but you might be paralyzed for the rest of your life, like FDR was, right? And so that's another one that's really obvious there. So we'll talk about syndromes next. So a syndrome is whenever you have a disease that is defined by the signs and symptoms. So you might already be thinking like, well, which ones aren't? But no, I promise. So it's defined by the signs and symptoms instead of what causes it. Of what causes the pathogen. All right, example. You go to urgent care because you've been having a runny nose and a sore throat. You've had a fever of 101 to 102 degrees. You are really, really tired and your muscles are super, super sore. And you've had a headache too. They're going to test you for the flu and for COVID probably, right? Well, they're not going to diagnose you as having respiratory illness. They're going to diagnose you as having the flu or having COVID. And if you don't have the flu or COVID, then they're probably going to say you have a cold. Now, cold doesn't usually have a high fever like we would see or a headache associated with it, but you might still be achy and tired and have a runny nose and a sore throat. A cold is the common cold, can be caused by, it's usually related to specific upper respiratory symptoms. And it can be caused by any number of like 200 different viruses. Whereas the flu is caused by influenza. COVID is caused by the COVID virus SARS-CoV-2. Tuberculosis is caused by tuberculosis. The plague is caused by Yersinia pestis, the plague bacteria, and so on and so on. Ebola, it's caused by the Ebola virus. So those are diseases that are defined by the pathogen. One very obvious, so if the cold isn't ringing as obvious to you, that's okay. One that will be, let's imagine you have a patient that has a headache, a stiff neck, a fever, and light sensitivity. What is that? Meningitis. So many of us know that right away. If they've got a stiff neck and a fever, especially, those are like the two biggies. That light sensitivity and the headache on top of it is just the icing on the cake. That person has meningitis. And that's defined by the signs and symptoms and what's really going on with the body, which happens to be inflammation of the meninges, which is the covering of the nervous system. So we have inflammation of the meninges, and we're defining it by those signs and symptoms of the fever, the headache, and whatever. What can cause meningitis? A bunch of different kinds of bacteria can cause it. A whole ton of different viruses can cause it. And then several fungi can cause it too. But we're still defining it by the signs and symptoms. So that's a really obvious syndrome there. Some other ones, when we talk about Down syndrome is defined by the signs and symptoms associated with it. But one of those signs is having 3 of chromosome 21. Trisomy 21. You happen to have 3 of those chromosomes. That's a sign for having Down syndrome. as well as we say facial features and learning disabilities and things like that that come along with it, okay? AIDS, acquired immunodeficiency syndrome. In order to have acquired immunodeficiency syndrome, you have to first have had HIV. Now, if you have HIV, do you have AIDS? No, you can have HIV and be HIV positive, but not have AIDS. AIDS is defined by having HIV and having a low T cell count and having opportunistic infections. Those are all equated with the signs and symptoms associated with that syndrome. So again, diseases that are defined by the signs and symptoms as opposed to the causative agent. Make sense? Good. I often see people confusing syndrome and sequelae. But if you remember that there's Down syndrome, for example, you'll remember that it's a separate kind of disease. They are defined by their signs and symptoms. Sequelae are, think of it as a sequence in a series. Sequelae, a sequence. The last, like you get over the disease, the next thing in the sequence is now you have these lasting effects of the disease. Anybody in here have chickenpox in real life? Okay. Did you guys get any scars from chickenpox? So me too. So I have them all over my body. Those are sequelae. They're not really harming me, but they are lasting effects of having cleared that illness. Cassie, you must be lucky. My mom, I don't know. Okay, yeah, that's not lucky then. Yeah, shingles is not lucky. Yeah. Oh, that sucks. Yeah. I'm not looking for, I know it's going to happen at some point. I just feel it. Unless I get you can get the shots for it, but they don't work 100%. They're not 100% effective. So I'm in my 40s. They start giving the shots for it in your 50s. All right. Question 9. What is the term for the phase of infection that involves decreasing signs and symptoms? So we got Duncan. We're good. Julisi, you'll be our next. Is Julisi? I always just say it. Julisi. It's not, it's just for me. Okay, so Julisi. Okay, so my question for you is, what is the prodromal phase?
Right before or when the.
So it is, yes. So we'll talk about this. So that is relating it back to that growth phase. So we'll give a little bit more definition to that too. So that is good. I'll accept that definitely as an answer. So when we learned about the growth phase of our bacteria, this was our growth phase, right? And you guys remember this. This was the lag phase. This is whenever the bacteria was getting adjusted to being a new environment. And then next phase was the exponential or the log phase. The next part was the stationary. We're basically at the max population that setting can handle. Max population. We're not going up anymore, and we are not able to handle more growth in that area. Then we had that death phase. So again, this was from chapter 9. All right. To equate this stuff to it, when you're in the lag phase, this is what our incubation period is. This is basically, you already know that an incubation period exists, right? So from the moment that if I have COVID and I come and cough on Duncan over here, does Duncan immediately get COVID symptoms? No, there's like a delay of between 5 to 14 days from whenever he's exposed to whenever he starts having signs and symptoms. That delay period is called the incubation period, and it differs for our pathogens. Then we have the first signs and symptoms. And like Julisi said to us, the first signs and symptoms is the prodrome. The prodromal phase or the prodrome, they're the same thing, however you want to put it. In the prodrome, again, first signs and symptoms, because this is when we're first entering that exponential phase. We're starting to have multiplication of the pathogen. This is whenever you wake up in the morning and you have that scratchy throat and you just know you're coming down with something. That's your prodrome, your first signs and symptoms. Okay, once you get full blown with that infection and it's reached its max, so anywhere from about here through here, full blown infection happening. We call this the acute phase or the infection phase. There's one other one that it called it in the book. which might be something else, but it doesn't really matter as long as, and there might be incubation phase, just whatever. They all mean the same thing. And that's why I don't ask many questions on the test about the acute phase, because depending on your source, they might call it something else. But this is your full-blown infection. This is when you're at your worst that you're going to be experiencing with the illness. The worst of that illness. And then obviously, as the microbes die down, we have a decrease in the signs and symptoms, and that's convalescence. For those of us who need to make a paycheck, this is usually when we start going back to work. Have we cleared the microbe completely? No. Could we still be contagious? Yes, we could be what we call convalescent carriers. So a carrier, again, is somebody that is infectious and can get somebody else infected. What makes a carrier a carrier? They're either asymptomatic completely, so they don't even know they're sick, or they are subclinical. They are maybe somewhat ill, but they're still willing to go out and go to work and engage with other people. Or they're convalescent carriers. They're starting to feel better, and so they think they can go back into society and get people sick. So all three of those situations could lead to a person being a carrier of a disease. All right. Any questions about this? Clear it. All right, what is a fomite? Evelyn, you'll be my next person. I saw you were online. Evelyn, I want you to give me an example of a fomite or a situation. That would be a fomite. All right, so a fomite is any vehicle for an illness. So for our vehicles for our illnesses, we have living and non-living ones. Our vehicles for transmission. So a phone case, perfect. That's a great example. Okay, so we'll give some other examples as well. So for our vehicles for transmission, for our non-living vehicles, these are called fomites. Examples, like we had with Evelyn's example, was a phone case. That makes sense. You've been touching a phone case, and now it has your bacteria or your sick germs all over it, and now somebody else could touch it and get sick from it. So obvious, that's an obvious one. Your phone case, pens, tablets, keyboards, but the most obvious one that I feel like we sometimes overlook because we're so used to interacting with it is like doorknobs. Doorknobs are a very obvious one. So doorknobs is the best example that I have. Non-living. Now, is the doorknob infected? No. An infection, remember, is whenever the microbes are multiplying. They are growing in that environment. The doorknob is just contaminated then, but it's non-living and it's just serving as a means to transfer the microbes. So those are fomites. Our living vectors, our living vehicles, excuse me, living, we call them vectors then if they're living. And there's two different types. Put a little line here so we don't mix it up. Biological and mechanical. Biological vectors are actually infected. Examples of this would be like birds with the flu or mosquitoes. Mosquitoes with malaria. The mosquitoes are actually infected with those illnesses when we're talking about them. Whereas a mechanical vector, mechanical living vector, an example would be that they're just carriers, carrying physically. Don't let that confuse you too much because you already know good examples of this. Examples would be flies and cockroaches. So flies will land on poop and they land on your food and now your food is contaminated. Were the flies actually infected? No, but they are a living thing that is engaging in spreading that disease. Yes. With Yes, so I would say those would be probably biological vectors because they're actually infected with those diseases. They might not, so Dylan brought up about how armadillos can carry disease, like including leprosy, right? And so they can be infected with leprosy, with the bacteria for leprosy. And they're infected, but they don't necessarily have signs or symptoms of it. So they're carriers of it, but they're still infected with it. They're still biological vector. Yes, but if they're just a physical means for transmitting that disease, like flies and cockroaches, then they would be mechanical. Does that make sense? Again, on the test, I'll try to keep it with obvious things for you guys for that. All right, let me make sure we don't have any people that are missing. We had Evelyn. Okay, Asley, you'll be my next one for whatever's coming up next. I don't know what. I think we're done with this chapter, aren't we? Yes. So I'll ask you a question in the next chapter. We'll do our activity for this one first, but it shouldn't take too long because I think we've touched on some of the topics already. You guys are always killing it too. Don't get me wrong. I like my Tuesday morning class, but they ask so many questions. It ends up taking like a ton of time. And you guys are always welcome to ask questions. I'm not saying don't ask questions. By all means, ask the questions, but they ask so many that it ends up going over time almost every time. All right, our activity for today. An example of an opportunistic infection and a disease caused by a true pathogen. So opportunistic infection, like we said with the UTI or vaginal yeast infections, how many times does somebody treat a UTI with antibiotics and then end up with a yeast infection? Yes, because the antibiotic kills out the bacteria and now the yeast were left there and now they can overgrow. That's something that we call, also in that chapter we learned about this, that's called a super infection. So if you only have a couple of yeast fungi taking up a couple of seats on your stadium seats, that's normal. They're part of your microbiome in the vagina. But if we take an antibiotic that clears out all the other bacteria, the lactobacillus species and stuff like that, then suddenly the yeast can overgrow. And that is super infection. And that's exactly what usually happens with C. diff. One thing that we know of with C. diff is that it's very common in hospitals. But do you see C. diff a lot outside of hospitals? Not really, because usually what happens is somebody's put on antibiotics. It kills out their normal microbes. The C. diff becomes an endospore and survives the antibiotics. Then it can overgrow and take up all those new open stadium seats in the colon and cause the disease associated with C. diff, which is called pseudomembranous colitis. And so that's a super infection as well. So anytime you have just a couple of potential pathogens hanging out in an area, we clear out the rest of the guys that are there and they can overgrow. That's called a super infection. So C. diff is typically a super infection situation. And that means C. diff is typically an opportunistic pathogen as well. Sometimes C. diff is introduced from outside of the body. Sometimes it's introduced from your own body. You already had some C. diff camping out. If it was introduced from outside of your body, it's almost always because it was in a hospital setting where it got transmitted from another patient. We don't usually see C. diff getting transmitted from person to person outside of a hospital setting. So, yeah. All right, we had an example of our virulence factors. We talked about capsules, fimbriae, flagella, even if you make certain kinds of toxins that are associated with illness there as well. Trying to think of something. I felt like there was another question on here and we didn't talk about it. Okay, it's this next question. That's duh. All right. Pathogen that causes malaria is a protozoa. Pathogen that causes HIV is a virus. Pathogen that causes tuberculosis is a gram-positive bacteria. The pathogen that causes cholera is a gram-negative bacteria. Which of these listed pathogens would have endotoxin? Does anybody know? Okay, good. So Julesi got this one, the gram-negative. Do you know why? There we go. Okay, so this is just a reminder, more or less. Coming back, it was from Unit 1, but it talks about it in Chapter 13 as well. So Chapter 13 talks about toxins. A toxin is anything that causes damage to a host. There's two types of toxins, endotoxin and exotoxin. Endotoxin is always that LPS, which is lipopolysaccharide, molecule on the outer membrane of gram negatives, period. That's what endotoxin is. It just is what it is. LPS, lipopolysaccharide, on the outer membrane of gram negatives, period. Exotoxins, on the other hand, they can even be enzymes that the bacteria secrete outside. So exo is what it sounds like. They're things that the bacteria makes and secretes outside of the bacteria to break down things in their environment. For example, I cannot tell you how many bacteria have the enzyme collagenase that breaks down collagen, which is part of our extracellular matrix that keeps our tissues together. So if bacteria can break down collagen, they can get deeper into the tissues and cause deeper infections. So collagenase, an enzyme, it's an exoenzyme. It causes damage to the host and therefore is a toxin as well. So those are examples of toxins that will be exotoxins, but endotoxin is always just LPS on that outer membrane of the bacteria, the gram-negative bacteria. All right, we already talked about nausea and vomiting, and we talked about syndrome. Anybody have any questions about any of that stuff? All right, we'll go on to the next one then. Chapter 14. Let me change the settings on this. So I can see my writing a little bit easier in case I need the writing. All right, so just double check that you take a breather and double check that you're signed in. Asley will be our first person up. And I think I got everybody. I'll double check that. Cielo and Sonia. I don't see either of them. All right, get into it. So chapter 14 was epidemiology. There's a lot of terms in this one. All right, first one is, who is Jon Snow? Not from Game of Thrones. Turns out Jon Snow was not Ned Stark's son, if you didn't watch the whole thing. Spoiler alert. All right. So Jon Snow stopped a cholera outbreak using epidemiology. This was in London, basically like he mapped out like outbreaks of cholera outbreaks in London on a map and then realized it was centralized around a certain water pump. So he took the handle off of it and lo and behold, it stopped the outbreak. So he's considered to be the father of epidemiology. Does anybody know who Florence Nightingale is? It sounds like she would sing, but she's not a singer. She is considered to be the mother of nursing. And so she actually employed hygiene practices during the Crimean War. She noticed that the soldiers were coming in with not coming in with dysentery, they're coming in with stab wounds from bayonets and things like that. But they ended up getting dysentery, and it didn't make any sense because dysentery was an oral fecal transmission. And so she found out that if people washed their hands, the healthcare workers washed their hands, and we used like sterile sponges and things like this, that the people were less likely to get dysentery. And so she's considered to be the mother of nursing for employing hygiene practices like that. So that wouldn't be where your question's coming from. We're gonna wait till we get some content. All right, which term refers to the total number of existing cases with respect to the entire population? I'm gonna ask you an easy question about one of the ones that's the wrong answer. So all of these terms are relevant in epidemiology, and it's just a matter of, let me get this away. It's just a matter of what they mean. All right, so prevalence refers to the total number of cases that are existing. So the big idea here is that total number of cases that exist, all right? If we have a certain number of cases in the week, or what we often see with the CDC and other like healthcare like companies and stuff like that, they'll come out with like a monthly morbidity and mortality report. And so that monthly is the key for incidence and morbidity rate, okay? So monthly, if we have how many cases this month, how many cases this week, how many new cases today. Those are incidence or morbidity rate. They are the same thing. My question for Asley is, what is mortality rate? The death rate. Yep. It's talking about how many people died from the disease. Yes. So pretty straightforward, not meant to be crazy. All right, so be sure that you know the difference between prevalence and incidence, because obviously a lot of people get confused between the two. But incidence is like talking about a specific time frame, how many outbreaks. Whereas that prevalence is like the total number of existing cases, period. All right. Next question. Which type of outbreak occurs when pathogens come from one single source at the same time? All right. There are three major outbreak types. So we mostly got this one, which is point source epidemic. A point source epidemic means that it all came from the same place at the same time. As opposed to a common source, which sounds similar, but they aren't. Same place over time. What that means is when we had that, okay, if I had COVID right now, and three of you guys went home and you got COVID, that's a point source, right? One point in time, are you exposed to me today? I got you sick today, right? Common source. Jon Snow's situation with the cholera. People were going to that water pump over weeks and they were all getting sick from it. So that's over time. So that's common source. It all came from a common source, but not at one point in time. So point source, we're talking about the point in time there. So if you can focus on that, it'll help you out. The third type of outbreak is called a propagated. A propagated epidemic is one that is maintained in the human population. For example, COVID right now. Make sense? Yes, question.
Medical college better be like radiation sickness with
Yeah.
over time.
Yeah, and you could still keep going back to Chernobyl and even get radiation sickness even today. That's not everybody getting exposed to at one point in time, but can continually be exposing persons. That's a good example. So his example was like Chernobyl. If you keep going back there, you can still get radiation sickness over years and years and years, but it's a common source, which was at that Chernobyl meltdown at the reactor. Makes sense, yeah. Yeah, and propagated epidemic, like we said, COVID right now is being maintained for years in the human population, and it's mutating within the human population. It's a propagated epidemic. We're propagating it within our human population. Yeah.
What would, like, exposure to chemical, exposure to chemical warfare, elements, would that be common source, or would that be?
That would kind of depend, right? So depending on the chemical, if you are exposed like to mustard gas and you get your whatever illness from that one exposure, that would be point source. But if it's a chemical that may, is there for a long time and people walk into the area and get sick again, then that could be common source. I wouldn't say probably, that's a tricky one.
I'm just trying to.
Yeah. I mean, if like, let's say you're exposed, like, let's say somebody, comes into the room and gives us anthrax. And we all get the anthrax from that one exposure. But now the people we go in contact get the anthrax from us, and then they keep giving other people anthrax and they start propagating it that way. So then I would say that initial exposure, the initial outbreak was a point source and now is being propagated after that. So I'd probably separate the two as different events. if that makes sense. And you could probably pinpoint it and say, you know, yeah, all of these people were exposed to anthrax in this point source epidemic. And then, you know, Professor Yost was the one that passed on to her family, and then her family passed on. So she was the source for a propagated epidemic after that, if that makes sense. Yeah. Not a bad question. All right, let's get on to the next part. True or false, a pandemic is the spread of an epidemic across continents. All righty. So this is true. It's pretty straightforward. Most of us know what a pandemic is by now, but the real definition of it is that it crosses continents. So for our epidemic types, epidemic, or how do I want to talk about those? Outbreaks, source, outbreak spread types. You can have a sporadic situation where these just a random oh my gosh. If I were to go outside and get bit by a rabid raccoon and get rabies, sporadic. If somebody came here from traveling to Africa and they had Ebola, and they had Ebola and the healthcare workers that they were in contact with got Ebola, but it stayed just within that, I'd still consider that sporadic. We're not having a true outbreak going on. It's just a random sporadic case, random situation. It's not really spreading throughout the population. It's like a localized event. So random cases would be sporadic. Endemic. This is when a disease is found at a steady level in a location. Steady and predicted. We're getting into the fall. Would you guys be surprised if somebody were to say they got a cold? Probably not, because it's endemic here. It's common to get that illness, okay? Epidemic. Anytime you are exceeding the endemic levels. Now, when we had COVID outbreak here, now I know we already agreed that it is a pandemic because it crossed continents, but if it was only here in Oklahoma, let's say, that would be an epidemic because our endemic level of COVID was 0, and now we've exceeded that, so that would be an epidemic. Then we have pandemic, which obviously is once a epidemic crosses continents. Obviously, COVID now qualifies for this. I mean, has qualified for this for a long time. All right, any questions about those terms? And again, chapter 14 is a very flashcard friendly chapter, okay? So I would say those are epidemics just because we don't see it constant. You know what I mean? So like if we have the flu come out every winter, well, it's an epidemic while it's coming out, but it's also endemic because we expect it to be at those levels. So it depends on like kind of what scale you're looking at and like what maybe what time of year it is and stuff like that. If you're expecting to see 1,000 cases of flu in the winter and you get 1,000 cases, then you might say that's endemic. But if we're getting 100,000 cases of flu in the winter, then we might say that's an epidemic, right? Because it's very far outside of what we're expecting. So sometimes our perspective matters when we're calling something sporadic or endemic or epidemic. But yeah. All right, let's move on. Next question. Which term refers to a disease that is at a steady expected frequency over a long time in a particular place? Alrighty, so this would be endemic. We should get this one. I have it written up here, so it's pretty much giveaway. Job. Alrighty, what aspect of a test is related to a low number of false negatives? So we're gonna go over this one because this one trips a lot of people up. It might not in this context, but always does on the test. Okay, when we're looking at the effectiveness of a diagnostic test, there are two factors that we want to pay attention to. Specificity and sensitivity. All right, so how sensitive is the test and how specific is the test? And the terms, they make sense to you in your mind right now. We were talking about how specific are you trying to be, or how sensitive is the test? Those are different words to you in your brain, but for some reason, when we get to putting it into this context, it starts to go a flutter and we start mixing them up. So sensitivity, how sensitive? I always start with this one because it's the easiest concept for me to understand. How sensitive is the test? The idea is that you are able to identify all positives even if there's only one. How do I word this? All positives isn't really the right way. All positives, even if there's only one pathogen. One virus, one bacteria, whatever. An example of this. Home COVID tests. If you, let's say you've been feeling sick, you've been having respiratory symptoms and you're just feeling like crap and you've got a fever and stuff like that. You take a home COVID test and the home COVID test is negative. Does that absolutely mean that you do not have COVID? No. What is a more sensitive test that you could do that would be more reliable for whether you have COVID or not? PCR. So you guys already know the difference in sensitivity tests, right? Because we know PCR is more sensitive. Example, PCR, more sensitive than a home test. The result of having a high sensitivity is that we will have low false negatives. What's a false negative? Anybody know that one? It means we call it negative when it's actually positive. Okay. So the more sensitive a test is, the fewer false negatives you'll have. We want a test to be sensitive, right? We want it to always say, if this person is negative, we want to know that they're actually negative. So the more sensitive a test is, the less likely false negatives will be. Okay, so one of my students pointed out to me, sensitivity has an N in it. And again, low false negatives, N. Okay, now we're going to move on to the other one. Specificity. You are able to tell the difference between the pathogen, between the target, whatever your target is, and something that looks like it. This is a harder one to give an example for, so I usually go for a drug test. You know that you can take Sudafed and pop positive for methamphetamines on a drug test. Most of us are aware of that. right? Because methamphetamine has pseudoephedrine in it, right? But if you've taken Sudafed and you test positive for methamphetamines, were you actually positive for methamphetamines? No, you had something that looked like it. That's a false positive, right? So you guys know this as well. So example would be positive for meth when you just took Sudafed. They look similar, but they're not the same. It's a false positive. False positive. Again, when you test positive, when you're actually negative. Now, another thing that I want to remind people about this, and again, we've got false positive. The more specific a test is, let's actually back it up. More specific a test is, the fewer false positives. And that makes sense. If we're specific for methamphetamines, we won't tag Sudafed as positive. It's because it's not very specific that it gives us the false positive. P. P. Okay, so this is one thing that another student pointed out to me, was those P's and the N's. I don't know how much it helps you because you have to have context around the P's and the N's. So again, the more specific, the fewer false positives, the more sensitive, the fewer false negatives. You want a test to be both highly specific and highly sensitive. You want both. Okay, any questions about specificity or sensitivity on diagnostic testing? This will absolutely come back up again in Unit 3 when we start talking about our diagnostic tests and the different ones and how they work. Okay. Cool. Next question. Where are we at? 7. What are Koch's postulates used for? I'm going to clear my screen of my notes. If you guys ever do join in on Zoom, you can also write on the screen with the Zoom tools if you have a computer. It's harder to do with a phone, but you can do it with the computers. So if you're ever talking to me, you can literally like circle something or whatever. Okay, so Koch's postulates, they are steps to help determine the causative agent, also known as the etiological agent, the thing that caused whatever the disease or outbreak is. So Koch basically took like people and then cultured whatever wounds they had. And then once they got a culture of whatever the organism was, he put it into mice and it replicated the disease that the people had. And therefore it was showing him that that was what caused the disease. He discovered the cause of anthrax that way. Seems like an obvious way to go about that method nowadays, but back then, remember that germ theory was brand new. So this was his way of basically determining what agents caused certain diseases. All right. 2 factors are collected at a single time with no reference to which may have occurred first. This is a type of epidemiological study. So study types is what we're going to go over next. Epidemiological studies. There's 3 types of these. All right. So the 3 types of epidemiological studies. I'm going to start with cross-sectional. Cross-sectional, which is this one. At a single point in time, we're going to look at characteristics. And it's usually 2. So for example, people getting sick, we're gonna go out and just pick some random people and say, do you have these signs and symptoms? And do you test positive for the PCR, for example? We're not picking people who are sick versus people who aren't sick. We're just saying, at this moment in time, we collected 100 people. Now, do they have this sign and this symptom, or do they test positive or whatever? Okay. The next one is a case control. Here, we are specifically picking people who do have the disease, which are people that are cases, versus people that don't have the disease. This is the control group. And then we're comparing the 2. So specifically now we've chosen people that do have the disease versus those that don't. The last one is called a cohort study. This is looking at 2 populations over time. Usually we have an at-risk population versus not risk, and then looking at them over time. The key here is that over time. It's usually over a long period of time. An example of this, again, something you're probably familiar with even, is if I take a population of smokers and a population of non-smokers, cigarette smokers versus non-smokers, and I watch them for 10 years to see which population gets lung cancer. That would be a cohort study. Make sense? Any questions about the studies? Like I said, this chapter is a lot of terms. It's very flashcard friendly. There is a randomized sort of situation, but I'm not going to test you guys over that. These 3 are the 3 that I will test you over. The textbook talks about another one. So I feel like it gets tricky compared to the other 3. Okay. Next, what term refers to how many susceptible people on average one person will spread the infection to? You're sick with COVID, how many people are you going to get sick? Disease tracking, I guess. So this is R naught or R sub 0. R naught is basically a measure of how contagious a disease is. When we talk about diseases, some diseases are communicable. And if you are very communicable, we call it contagious. Some diseases are non-communicable. What kind of disease? Well, I can see infection. It's even specifically with infection. Not all infectious diseases are communicable. For example, if I get West Nile virus, are you going to get West Nile virus from me? No, it doesn't spread from person to person. It spreads from the mosquito biting you. It's non-communicable. It's not contagious. Some diseases can be defined by how contagious they are as well. For example, the most contagious disease that we know of in mankind is the measles. To put it in perspective, COVID, it's pretty contagious, right? We'll agree. Most people have had it, right? The R naught for COVID is somewhere between 5 and 6 right now, maybe up to 7 by now, but somewhere between 5 to 7, we'll say, depending on the strain and stuff like that. So if you have COVID, you're likely to infect 5 to 7 other people. If you get measles, the R naught is 15. You're likely, if you have measles, to infect 15 people if you have the measles. Unvaccinated people, okay, if we were unvaccinated. So that's one of the most contagious diseases that we know of. But this put into perspective, if you're sick with a disease, how many other people are you likely to infect? We have diseases that are pretty low, R naught, some that are almost 0. There are contagious diseases that are unlikely to be transmitted, like rabies. If I get rabies, the likelihood that you're going to get the rabies from me, the R naught is not even 1, right? We wouldn't even infect, on average, one other person. Number one, other people know to stay away from somebody that's behaving that way. Number two, the likelihood of me getting somebody infected, it's low, right? So it's a very low R naught. It's still contagious though. I would say it's still communicable. I could give you rabies if I bit you and spread it to you, but it's unlikely that it's going to happen, right? As opposed to measles, just being in the same room as another person that has the measles, they don't even have to cough or anything and transmit it. So this also leads into that case fatality rate, CFR, case fatality rate. Similar to mortality rate, okay, but fatality rate here is the number of people that would die if we don't treat the disease. So untreated mortality rate. Oh, come on. The key there is that it's untreated. All right. So ones that have 100% case fatality rate. I named two, but someone else brought up another one. The one that they brought up was prion diseases. Prion diseases like mad cow. 100% fatality rate. The one that we talk about all the time in class, do you guys know which one I'm talking about? Rabies, 100% fatality rate. And there's one third one, which is HIV. Again, untreated HIV is 100% fatality rate. There's not many diseases out there that are 100%. Even Ebola is not 100%. It's 80 to 90% for the worst strains of Ebola. People still survive that just fine. But people don't survive prion diseases, HIV, or rabies. They die. Yes.
What makes plague so bad?
The plague was as bad as it became due to people living close in proximity to one another, as well as they didn't understand about germs back then. So, I mean, we're talking like the 1200s to the 1400s, even earlier than that, we had outbreaks of plague, right? People had no idea that germs were the cause of it. And they didn't know that the fleas were transmitting the germs either. So they had no idea. They just thought bad smells. They thought that if we cover up bad smells with good smells, we won't get sick, which is wild, right? But they really thought that. So, yeah, so that's why the plague was so bad. And even the plague, we're not even looking at 100%, even back then. I mean, it was people still survived that and went on to live. And so it's pretty crazy to think about when we talk about case fatality rate being 100% of something. Again, untreated, but I want to be very clear about this. There's no treatment for prion diseases or rabies. No treatment for those. So those are always 100% fatality rate, period. HIV has a treatment, or now you can have HIV and live a perfectly normal life and not get other people sick and live with this disease that would be 100% death rate if we didn't have the medications to treat it. Pretty amazing medical advancement there. But yeah, cool stuff, I feel like. The other thing that's on here is herd immunity. Herd immunity is the idea that with certain diseases, based on how contagious a disease is, how many people have to be vaccinated to prevent the non-vaccinated people from getting the disease. So this is based on contagiousness. How contagious? We'd say R naught is a measure of that, right? Based on the R naught, how many people have to be vaccinated? To protect the unvaccinated. So I'm pointing something out really quick. We essentially almost eradicated measles from the United States of America. Now, it's back, obviously. We have to achieve 96 to 97% of the population to be vaccinated against the measles in order to protect those that can't be vaccinated. So that means that 97% of us need to be vaccinated, and then we can protect 3% of the population. That 3% would be babies and elderly people whose immunity is failing, or people with immune system disorders that can't make their own immunity. And we might be able to handle a few other people that might have religious reasons for not getting vaccinated. Now, point something else out. I grew up in an era where you couldn't go to school if you weren't vaccinated. Right? I mean, quite literally, you had to provide vaccination documents to attend public school. And I'll also point something else out. The people who are actually advocating for anti-vax are almost always exclusively vaccinated people. Isn't that interesting? Just saying. Now, the kids might not be vaccinated, but they almost certainly had to be because they grew up in the same era that I did, which required that we be vaccinated just to be out in the public, pretty much. And I mean, it was definitely one of those things where I talked to my mom about it. She's one of those people that is, I'm just going to say she's more right. Okay. She's conservative. And she was arguing with me about how, oh, when you were a kid, I didn't get you all your vaccines. My mom, I love her. Okay. I'm going to be honest, but she's a liar. So that absolutely wasn't the case in the 80s. You were wild in the 80s if you didn't get your kid your vaccine. People would look at you like you were insane. I mean, what were you thinking? And that's what I'm not saying that there's a right or a wrong with this. People are founded to be worried about vaccines and their safety. There are issues with that. But in the 80s, people did not look at it that way. People looked at it as, you got your vaccines, why wouldn't you not get your vaccine? I guarantee you in the 80s, when I was a kid, early 80s, my mom, and I had the vaccines to prove it. She didn't delay any of my vaccines, nothing like that. She was there for every appointment as soon as possible because that's what she did, that you were supposed to do. So are all, many of these people that are anti-vaxxers. They're my age. They were vaccinated because you had to be, just to be in society. And if you didn't get to go to public school and probably private schools. You probably were homeschooled if you weren't vaccinated. So I'm not saying that you have to get all the vaccines always and forever and that there's no harm in them. I'm not saying that. What I am saying is that I find it interesting that people are vaccinated and they're telling you not to get vaccines. But now there are kids that aren't vaccinated are going to end up with the measles and end up in the hospital, and they're going to have meningitis or encephalitis and die. And who are they going to be crying to about it?
About the kids that have diabetes,
Mhm.
they decide not to be vaccinated.
Yeah.
And then they end up with the hospital with their sugar and it's not just one thing.
Just saying. So herd immunity is the idea that we would get vaccinated, we can protect other people, and we can even eradicate diseases this way. It's how smallpox got eradicated. It's why we don't have smallpox on the planet. The last case of smallpox was in the 70s. So we have not seen smallpox since the 70s because of vaccination efforts. Now, we didn't have to get 97% to get rid of smallpox. We had to get a much smaller number for smallpox. It was still a very highly contagious disease, though. But anyways, just putting that into perspective a little bit. That's the idea of herd immunity. Now, vaccines do have risks involved in them. And this chapter does talk a little bit about that. And so does the chapter 16 that we'll get to in unit 3. Yes. Mhm.
That would be considered propagated.
It was propagated. Exactly. Yes. It was a propagated epidemic. Humans were maintaining it throughout the population over time. Absolutely. Okay, good. So I'm going to go on to the next question. I'm going to leave this stuff up here because I think the next question has to deal with this one. Yes, the last one. Case fatality rate. Whoops. I did see the chat. No worries. I'm going to see it just a second. Okay, so case fatality rate is the likelihood that you will die if untreated from a disease. So good job with that. Yes, you can. Maria, if you have a question about lab midterm, we're going to do the lab midterm next, but you're more than welcome to ask it any time. Yes.
I had a question over the acid fast stain. Is that just for gram-positive bacteria that have mycolic acid?
Yes, so you can think of acid fast bacteria as being a subtype of gram positives. So if you're gram positive, some gram positives are acid fast, and some gram positives have endospores.
Okay, so it's never going to be gram negative, correct?
Right, correct. Yes.
Okay, thank you.
Yep. Let me double check really quickly. Make sure I didn't miss anybody. I did not. Okay. All right, so that's it for chapter 14. We have our activity for chapter 14. We're still early, man. And we'll definitely take a break because I don't want to start too early with the lab review in case CLO or Sonia show up since not everybody is here. So we'll take our time with this exercise. Okay, I'm trying to escape. There we go. All right, so here is a study, an epidemiological study for COVID. And here they used a cross-sectional approach, it even says it at the top here, for viral load distribution. We basically said there's an outbreak of COVID happening. Let's take 1,000 people and see, do they have PCR positive or not for COVID? They use PCR as a determinant. So basically looking at that. That was the idea here, looking at viral loads as well as whether they had symptoms or not. So during the COVID outbreak, took a bunch of people. Do you have viral load based on PCR and do you have symptoms associated with COVID? All right, so cross-sectional here. So why is this style of study considered cross-sectional? Because we're taking a moment of time and looking at a group of people. We're not looking at people who have the disease and have not the disease and then compare them. We're saying a whole bunch of people. Do you have positive PCR or do you have signs or symptoms? So they look at PCR to look at viral loads of COVID and seeing if it correlates with symptoms. What factors aside from viral load could affect the severity of the symptoms? This is a pretty important factor, especially whenever you're thinking about the patients that you might be treating. Why might somebody have worse COVID symptoms than another person and it not have to do with their viral load? So this has to do with their immune health too. So how healthy is their immune system? And that can correlate with age sometimes. It could correlate with age. It could correlate with their healthy living situations. Other things that we could consider in medicine, we call them comorbidities. Do they have diabetes? Do they have some other sort of respiratory infection on top of also COVID? Are they a smoker? And stuff like that. So these are all indicators that could affect the severity of the symptoms that are not being tracked in this study. The study uses cross-sectional data as a predictor of the epidemic trajectory. Why might this not be ideal? Instead of, I'm not saying that cross-sectional studies are bad, but there's just one way of looking at the data, right? So if we're looking at a whole group of people and saying, do you have the virus? And do you have signs and symptoms? We could take a group of people that have the disease and signs and symptoms and that those that don't, and then look at viral load and compare them. We could also look at living situations. We could also look at where in the city are they living? Are they inner city or are they upper class? Stuff like that. So these are leaving out a bunch of factors that could also be affecting the data. I don't know how their data distribution was. I don't know if they took different populations of different types of people in different areas, but if they didn't, then that could be another factor of the outcome of the outbreak. Yes.
So it is like severity of COVID. Is that all about like,
Yes, absolutely. Yeah. So COVID severity could be a result of your genetic variability, which could tie in with your immunity and ability to fight it off, but also your genetics as far as like the likelihood that you can be more easily infected than another person. It might not have to do with your immune system, but literally like, do you have more of a marker that allows that virus to get into your cells more or something like that? But yeah, so there's that. So cross-sectional, it just depends on what data we're looking at with the cross-sectional study, and the more factors that we're looking at, the more we can learn about how that outbreak is working. So that's why it might not be ideal. Would necessarily a cohort study be more useful? Or would a case control study be more useful? I don't know, but they might allow us to see different types of data from a different perspective. Knowing what we know about how the COVID vaccine trains the immune system not to overreact to the virus, which is basically what it does. We still get infected, right? But we just don't overreact. We don't get the cytokine storm that puts you on a respirator. Instead, we see it as just a regular, like a flu or cold, normal respiratory virus. So if we did this study before vaccination, which is when this was done, and then repeat this study now after most of the population has been vaccinated, what type of change might we see in the outcome of that? Well, they're looking at signs and symptoms. The signs and symptoms likely are far less severe now. We'll still probably maybe even have more of the population be positive or viral load, but less severe symptoms, because it's definitely being propagated in society. It's not a rare thing. It's not like only random people have had it. Almost all of us have had it, but the signs and symptoms are significantly less severe. So that's probably what we would see if we did that now. So what would a case control study look like if we were looking at a COVID outbreak? Again, you look at people that don't have signs and symptoms versus those that do, and then compare data between those two populations and look for differences that could tell you more about that population and why these people have it and why these people don't. And so we could make comparisons that way. Obviously, neither one is perfect, but they're just different ways of looking at data during an outbreak. And that's what epidemiology really is. It's more like statistics. It sounds cool. And do they do actual science research behind it? Yes, they do some, but a lot of it is statistical analysis, which was not for me. I used to think I wanted to do that for a living, and then I realized math. And I was like, that's not for me. Not for me. Okay. Any questions about epidemiology stuff? All right, we're gonna have a little bit of a break. It's 6:20 right now. Get up, stretch, go have a vape. I don't know. And be back here at like 6:35. Because I don't want to start, we could technically start at 6:45. But again, we don't have everybody here, so I don't want to miss out on. So that might join us.